Hello, everyone. So I'm tasked today to talk about proper screening and surveillance for colorectal cancer and inflammatory bowel disease. I want to thank Dr. Sharada and the committee for inviting me. Thank you very much. So as an introduction, just to talk a little bit about colorectal cancer. As you all know, this is the third most common cancer worldwide. Sporadic colorectal cancers and colitis-associated cancer may actually develop in patients with IBD. So it's not only colitis-associated cancer that can develop, but also sporadic colorectal cancer. So what are the main risk factors for sporadic colorectal cancer? And I think Carla touched a little bit on that. We all know that these include increasing age, male sex, and a history of colorectal cancer and first-degree relative. But there are also some other what we call lifestyle-related factors, and these may account for about 20% of cause for sporadic colorectal cancer. And these include increased body mass index, low level of physical activity, cigarette smoking, and a high consumption of red meat, in addition to consumption of alcohol. However, these lifestyle factors have not really been assessed in patients with IBD. So what are the risk factors for colorectal cancer that are specific to patients with IBD? And I know, Carla, you touched a little bit about that, but let me just show this slide real fast. Patients that don't have any colonic inflammation and that have ulcerative colitis that is really limited to the rectum, they are not an excess risk for colorectal cancer, not, okay? Patients with high risk for colorectal cancer are patients with PSC and IBD beginning at the time of diagnosis. Patients that are an excess risk of colorectal cancer, when you compare this to risk among persons of the same age and sex without IBD, this actually depends on the colonic inflammation of extension, duration, and severity, okay? And that's all I'm gonna talk about risk factors, all right? So let's talk a little bit about the pathogenesis of colorectal cancer and IBD. Well, we all know that inflammation definitely plays an important part. So let's start with a patient with colitis without dysplasia. I am not a geneticist, and I don't wanna be, but let me give you my limited knowledge about genetics and what I've read. So it all starts with inflammation, the immune inflammatory response, which actually induced direct DNA damage and induced NF-kappa beta and STAT3 activation, which actually inhibit apoptosis and cause transformation of normal cells to malignant cells. In parallel to this, there's also some genetic alterations that cause early loss of p53 and which subsequently cause mRNA and microRNA activation. And all of this, both the inflammatory response, the genetic alterations, end up in causing indefinite or low-grade dysplasia. If this goes on further and the inflammatory response is actually more and more not treated, this may cause also epithelium mesenchymal transition. And in parallel, further phylogenetic and genetic alterations occur that include this WNT MYC signaling and variable loss of KRAS and APC mutation, which then end up in high-grade dysplasia and colorectal cancer, okay? I know this is a very fast synopsis of the pathogenesis. Let's go on to the next one. So, having said that, what is the actual risk of colorectal cancer in IBD? Okay, what is the actual risk? Well, when you actually talk about the actual risk, you really have to study the full spectrum of IBD. And if you look at earlier studies that were done in the 70s, all these studies were actually done on patients with severe disease. But if you really want to assess the risk of cancer in IBD, you really have to study the true spectrum and population-based studies across the whole spectrum of IBD. Okay, so this is a very noted and well-cited study that was a meta-analysis done in 2001 that looked at the risk of colorectal cancer in patients with ulcerative colitis. And lo and behold, if you look at all these studies, okay, these were studies that were a soup of all kinds of studies: surgical series, pathological series, patients with mild, moderate, severe disease, and so on and so forth. And it actually looked at the risk, and look what they found: 18% by 30 years, 18%. Please remember that number because I'm going to come back to it. All right. However, in 2012, this is a person by the name of Teen Jess from Denmark, who has done a lot of work on this and on population-based studies for IBD and colorectal cancer. And what they did was a study, and they studied populations in Europe, mainly in Northern Europe, Denmark, Sweden, and also in Italy, and also studied in Canada and USA. So this was more representative of population-based studies. And what did they find? They found that the risk of colorectal cancer was actually low at a median of 14 years follow-up, 1.6%. Remember the 18% that I mentioned earlier? And if you look at the pooled relative risk when compared to risk with the average population, the risk was only 2 times. And this was confined to subgroups of young age and patients with extensive colitis. Similarly, in a meta-analysis that was done in 2005 in the risk of colorectal cancer in patients with Crohn's disease, they found the risk to also be pretty low, mainly about 2 times the risk of the general population. And again, this was confined to subgroups of early onset colonic Crohn's disease and severe disease. So having said that, and having shown to you here that the risk of colorectal cancer is actually in IBD, specifically UC and Crohn's disease, was actually low when you compare it, does the treatment that we give nowadays, biologics and immunomodulators, does it really decrease the risk of colorectal cancer? All of these studies that I just mentioned were actually in the pre-immuno era. Well, what about the last decade, or the 90s decade, of using thiopurines and anti-TNF alpha? This is the same author by the name of Teen Jess from Denmark that looked at the risk of colorectal cancer and ulcerative colitis in patients and in 3 different eras, okay? And what they did, they looked at the risk of colorectal cancer and ulcerative colitis. And they looked at 3 different eras, which is in the 70s, 80s, and 90s. And what you find here was that the risk of colorectal cancer was actually all close to 1, and all the 3 lines are very close to each other. But when you look very carefully, and remember, this is 35,000 patients, so you can actually conclude some nice conclusions from this. You will find that when you look at the last decade, which is the 90s, the risk of colorectal cancer was actually lower compared to the previous decades, okay? Now, they were not able to say that thiopurines and anti-TNF alpha actually decreased the risk, all because of the methodology they used and everything, but it's an interesting observation, okay? So I thought this was a very interesting study to look at. Well, having talked a little bit about risk factors, the risk of colorectal cancer, let me go down and talk a little bit about surveillance. So this is my outline for surveillance, and I'm going to talk mainly about dysplasia. So what does dysplasia look like endoscopically? It can be invisible, it can be flat, it can be polypoid, it can be in an area affected by colitis, or it can be outside in an area affected by colitis. I'm going to come back to this, to the pathogenesis, because I think this is important when you compare this to sporadic colorectal cancer. So in sporadic colorectal cancer, as you all know, The early event is a mutation in the APC gene, okay? So when you have a mutation in the APC gene, you form a polyp, and this then you have all these genetic alterations, which then lead to cancer. So the early event is actually the polyp, all right? However, in colitis-associated cancer, you have these genetic alterations that happen before polyp formation. So the polyp formation is a late event. So in colitis-associated cancer, there is really, most of these are flat lesions or maybe slightly elevated lesions. And this is important. Why? Because when we talk about surveillance, this is important. I will show you why. When we talk about dysplasia and when we talk about surveillance in patients with IBD for colorectal cancer, we cannot but really put a lot of importance on the Paris classification for colorectal polyps. And as you all know, the type 1P is the pedunculated, type 1S is the sessile, type 2A is the non-polypate and slightly elevated. And actually, this is what's actually mostly found in patients with IBD. You have the type 2B, which includes non-polypoid, type 2C, non-polypate slightly depressed, and type 3, non-polypate and excavated. So the scenic consensus, which was, they used the grade methodology, and this was published both by the ASG and the AGA. And this is terminology for reporting findings when you actually are doing surveillance colonoscopy for these patients with inflammatory bowel disease. And it's important to use this terminology. And the terminology is quite simple, actually. First of all, is it visible dysplasia, which is, they define that as dysplasia identified on targeted biopsies, okay? Invisible dysplasia is dysplasia that is identified on random, non-targeted biopsies, okay? They further divide visible dysplasia into polypoid, which is pedunculated or sessile, non-polypoid, which is superficially elevated, flat, or depressed. And then they use general descriptors, which include ulcerated, or are the borders distinct or indistinct, and so on and so forth, okay? So how is dysplasia in the colon diagnosed pathologically? Well, we all know that it starts with a normal mucosa. Subsequently, you have hyperplasia, dysplasia, and then neoplasia. So the definition of dysplasia is really histologically unequivocal neoplastic epithelium without evidence of tissue invasion. It is considered irreversible. It is considered the best and most reliable marker of the risk of malignancy in IBD. And this is very important. There are three categories: negative for dysplasia, indefinite for dysplasia, or questionable dysplasia, and positive for dysplasia, which is low or high grade. And it's often multifocal. So how do you diagnose dysplasia? It's really done at the histological level. There are two problems with it. And that is that the inter-observer agreement among pathologists may be low. In fact, if you look at the low-grade dysplasia, look at the kappa. It's quite low, 0.2 to 0.5. For high-grade dysplasia, it's 0.6 to 0.8. Still a bit higher, but still low. Molecular markers like P53 are not clinically useful for the diagnosis of dysplasia. Hence, that is why you need to confirm this by a second GI specialist pathologist. In fact, the ECHO and the European Society of Pathologists consensus statement on dysplasia in IBD states that dysplasia represents the best and most reliable marker of malignancy risk in patients with UC. Colitis-associated dysplasia develops only in areas with chronic inflammation and can be divided into four categories: negative, indefinite, and positive for low-grade and high-grade dysplasia. Inter-observer agreement is poor for low-grade and indefinite dysplasia. Confirmation by dysplasia by an independent expert GI pathologist is recommended. So how can you confirm dysplasia? Pathologically, high-grade dysplasia, you need to confirm it, and this is confirmation is helpful for high-grade dysplasia. For low-grade dysplasia, repeat biopsy is helpful to exclude actually low-grade dysplasia. And for indefinite dysplasia, repeat biopsy is helpful, especially after treatment of the colitis. However, there are really three critical elements for confirmation endoscopically, and these include a clean bowel preparation, inactive colitis, and very important high-definition colonoscopy. Now, whether chromoendoscopy adds or hinders is debatable, but let me just mention one slide on this. And this looks at newer colonoscopic techniques, and this actually shows that it is superior to random biopsies for detecting dysplasia. And this is a meta-analysis that looked at the diagnostic yield of chromoendoscopy for detecting dysplasia in patients with colonic inflammatory bowel disease. And as you can see from this meta-analysis, all of this favors chromoendoscopy. However, it is not known whether patient outcomes are actually improved. And we really don't know what the natural history of these small dysplastic lesions that were removed, what could have happened once you found them. So the debate is still on for this. So you've diagnosed dysplasia. Now, how best to manage it? Okay. What are the considerations that you should look into when you actually find dysplasia? Okay. First of all, how did you diagnose the dysplasia? Is it confirmed adequately? Is it low or high grade? How many lesions, dysplastic lesions, are present? Is the dysplastic lesion endoscopically resectable? Is the colitis well controlled? And what do the patient want? Okay, and that's very important. So how was dysplasia diagnosed? Well, there has been 3 eras of colonoscopy. This was during the era of fiber optic colonoscopy, and hardly any dysplasia was diagnosed back then. Okay, and you can see why. In the 90s, we had the standard definition video colonoscopy, and dysplasia was diagnosed a little bit better. However, lately in 2018, with the advent of high definition and lately dye spraying techniques, we are better at diagnosing dysplasia, and hence the use of targeted biopsies. So why is this? Why did I show you these 3 eras, and why is it important for surveillance? What are the implications for surveillance? Well, during the era of fiber optic colonoscopy literature surveillance, standard definition video colonoscopy, random biopsies were done. However, now with high definition video colonoscopy, better preparation techniques, better evaluation, we can do what's called targeted biopsies. Okay. So what do you do when you find dysplasia on random biopsies as opposed to targeted biopsies? This was a study that was often quoted, and it showed that you need 32 biopsies are considered necessary to have a 90% chance of detecting dysplasia in UC if it is present. And you need 60 biopsies to have a 95% chance of detecting dysplasia in UC if it is present. So you can see that the number of biopsies is huge. So the corollary to this is that the dysplastic field must be large to be hit in the random biopsy process. In fact, the scenic consensus 2015 showed that you need less than 1 to 1,000 random biopsies actually identifies dysplasia. So what do you do when you actually find dysplasia using random biopsies? In other words, this is endoscopically invisible. Well, this is likely to be a large dysplastic field for it to have been discovered. Hence, you need a second pathologist to confirm it. First of all, you need to see how many loci. Is it high grade or low grade? What is the presence of colorectal risk factors like Carla mentioned earlier? Persistently active colitis, PSC, families of colorectal cancer less than 50, and so on and so forth. These are the things, these are the considerations you have to ask yourself. How do you manage dysplasia discovered using random biopsies? Well, or endoscopically invisible? Well, the traditional teaching was 50% progression of low-grade to high-grade dysplasia or cancer in 5 years if you don't do proctocolectomy. And this is a study that was done in 2009. In fact, proctocolectomy was recommended in reasonable years in years gone by. However, more recent case series data suggests that there is a 5% progression rate among patients with targeted biopsies, and hence you need to refer to a specialist colonoscopist with optimal colonoscopy in 2018, find the lesion, should be endoscopically visible after treatment of the colitis, get the colitis in remission, and then treat it endoscopically. So how do you evaluate dysplasia when it is discovered using targeted biopsies? Well, most likely this is going to be a smaller lesion. However, you can actually better delineate the lesion now because you can look at the size, the pit pattern, the borders, any depressed areas. You can use the Paris classification. You can actually go back and do repeated sampling and tattoo that lesion. You can have histologic confirmation, and you can assess endoscopic resectability. So the echo actually helps us in this and tells us that a visible lesion with dysplasia should be completely resected by an experienced endoscopist, irrespective of the grade of dysplasia or the localization relative to the inflamed mucosal areas. And the areas of the absence of dysplasia and the surrounding mucosa, ongoing meticulous colonoscopic surveillance is appropriate. If endoscopic resection is not possible, or if dysplasia is found in the surrounding flat mucosa, then proctocolectomy is recommended. What is the risk of inadequate resection of dysplastic lesions and subsequent removal? And I want to pay particular attention to that. Everyone should assess their own skill sets when want to resect lesions endoscopically. And the ESGE recommends careful lesion assessment prior to EMR to identify features suggestive of poor outcome. Features that are suggestive or associated with incomplete resection and recurrence include lesion size more than 40 millimeter, ileocecal valve location, and prior failed attempt at resection. Consider referral to a specialist with advanced skills such as EMR and ESD. So what is the endoscopic approach that you should employ? Well, first of all, is it a polypoid dysplasia? If it is, then use standard snare polypectomy, cold or hot, and may use EMR. In fact, studies show that the long-term rates of colorectal cancer following endoscopic resection is about, in this study, about 6% developed colorectal cancer after about 5 years. And it's about a 0.5% annualized incidence among these 376 patients. The echo statement states, polypoid dysplasia can be adequately treated by polypectomy, provided the lesion can be completely excised and there is no evidence of non-polypoid or invisible dysplasia elsewhere in the colon. Well, what if it is non-polypoid dysplasia? Well, for EMR, there's few data on this. For ESD, there's one study from Italy that looked at 10 lesions, about 20 to 50 millimeters in diameter, and it found a 70% curative resection rate, and hence you need expertise for that. So what does the echo says about non-polypoid dysplastic lesion? These can be treated endoscopically in selected cases if complete resection can be achieved with no evidence of non-polypoid or invisible dysplasia elsewhere, and continuous surveillance colonoscopy is reasonable. Every other patient with non-polypoid dysplasia should undergo colectomy, regardless of the grade of dysplasia detected on biopsy analysis. Special considerations are patients with PSC, where there's a high risk of CRC. Dysplasia in these patients is likely to be multifocal, and most recommend colectomy even in the presence of low-grade dysplasia. Family history of colorectal cancer less than 50, and continuously active colitis that is treatment resistant, which is high-rate dysplasia and CRC. Difficult to survey well, then you should consider colectomy in these patients. So the CNEC and echo statement help us for continued surveillance. After complete removal of endoscopic resectal polypoid dysplastic lesion, surveillance colonoscopy is recommended rather than colectomy. The eighth statement says, after completely removal of endoscopically resectable non-polypoid dysplastic lesion, surveillance colonoscopy is suggested rather than colectomy. Okay, so two different statements. Just one slide about prevention of subsequent dysplasia. This is a meta-analysis that showed that mesalazine may be protective in patients with UC. However, this was not protective in patients with Crohn's disease. And I do not have data for thiopurines or for biologics. So the echo statement says chemoprevention with mesalazine compounds may reduce the risk of incidence of colorectal cancer in UC. There's insufficient data or evidence to recommend for or against chemoprevention with thiopurines. So having talked to you for about 22 minutes on surveillance in IBD, I'll tell you this is a Cochrane study that was published in Systemic Review in 2017. And the author's conclusion suggests that surveillance in IBD reduced CRC and CRC-associated death through early detection. However, the quality of the evidence is very low, and detection of early stage CRC in the surveillance group may explain some of the survival benefit observed. Okay, RCTs are unlikely to be undertaken due to ethical consideration. So, suggested algorithm for colorectal cancer and IBD. The AJA and ECHO suggest initial surveillance colonoscopy to begin 8 years after the colitis, or from the time of diagnosis of PSC, to which time random biopsy of the colorectum, or if the expertise is available, chroma endoscopy with target biopsy should be performed. The BSG, British Society of Gastroenterology, states initial surveillance colonoscopy after 10 years of colitis with chroma endoscopy as a preferred method. For subsequent surveillance, the ECHO and the BSG are in agreement here, and it says intervals are determined by stratifying patients on the basis of clinical pathologic features, which include low risk, intermediate, and high risk group. And the overall clinical management depends on the histologic findings and whether lesions are endoscopically resectable or not. And finally, my last slide. I will just show this algorithm real fast. So colonoscopy for cancer screening, if no dysplasia is found, the BSG and ECHO guidelines suggest to stratify into low risk, intermediate risk, and high risk. And if it's low risk, you repeat in 5 years, intermediate risk in 3 years, and high risk in 1 to 2 years. The AJA guidelines say repeat in 1 to 2 years. If it's indefinite for dysplasia, you repeat colonoscopy in 6 to 12 months. If it is low grade or high grade, then possible to complete remove dysplasia endoscopy with no dysplasia elsewhere. If that is the case, then if it is yes, then you repeat the colonoscopy within 6 months. Reappearance of dysplasia confirmed. Then if it's no, then you repeat colonoscopy 1 to 2 years. If it's yes, you consider colectomy. If it's no, then high grade, you do colectomy. If it's invasive cancer, then you do colectomy. So take-home messages. Risk of CRC is overestimated in earlier studies. Increased risk in IBD is confined to subgroups with long-standing severe disease, PSC, and a family of CRC. Dysplasia is the best marker for risk of CRC and IBD. Patients with long-standing colitis should undergo surveillance for dysplastic colorectal lesions. The optimal detection of dysplasia and colitis patient requires good control of inflammation, high definition white line endoscopy with or without chroma endoscopy. Confirmed dysplastic lesions colitis should be removed endoscopically if possible or surgically. And surveillance may reduce CRC and CRC-associated death in IBD. However, evidence is low. RCT is unlikely to be undertaken.